Okay, so hello everyone. For those of you who do not know me, my name is Erin Tersenio and I'm a PGY1 pharmacy resident. Today, I will be presenting my continuing education presentation on novel approaches to HIV treatment. As a disclosure, I have no financial interests, arrangements, or affiliations with any organizations. And if I utilize brand names throughout this presentation, it is included for identification purposes only. Our objectives for today will be to recall the human immunodeficiency virus life cycle and define autoimmune deficiency syndrome. We will compare various medication regimens used in the management of HIV and distinguish those from regimens utilized for pre-exposure prophylaxis and post-exposure prophylaxis. We will then discuss complications related to non-adherence and treatment failure and tie those into some new medications on the market, including a new long-acting formulation, as well as treatment options for multi-drug resistant HIV infections. I'll now transition into talking about the HIV life cycle. For a key, if I have these icons listed in my slides, they are utilized to show you what the drugs formulation are available as. It's important to understand the stages involved in HIV viral replication and know where the classes of medications work. As you can see on the right-hand side of this slide, there are 7 stages to the HIV life cycle. However, don't worry about trying to read this picture, as I will break this down step by step in subsequent slides. Thinking about the stages of an HIV infection, there are 3 stages. The first stage is the acute HIV infection that typically lasts around 2 to 4 weeks. And about 50 to 70% of patients will experience symptoms. Symptoms like flu-like symptoms, including fever, headache, as well as muscle weakness. At this point in the first stage, the virus is replicating rapidly, resulting in this phase being highly infectious. If we do not utilize anti-retroviral therapy, otherwise known as ART, which I will refer to as ART throughout this presentation, the HIV infection can progress to stage 2, which is the chronic infection, also known as clinical latency. Here, the virus is continuing to replicate, but at a much slower rate. Therefore, patients are typically asymptomatic. And the final, most severe stage is stage 3, or acquired immunodeficiency syndrome, also known as AIDS. AIDS is diagnosed with the CD4 T helper cell count fallen below 200 cells per cubic millimeter, or by the presence of an AIDS-defining condition. At this point, with the diagnosis of AIDS, the immune system is very weak and can no longer fight off opportunistic infections, including unusual fungal infections and specific malignancies like Kaposi sarcoma, which is an AIDS-defining condition. Guideline recommended first-line therapy includes lifelong daily oral therapy with anti-retroviral therapy, or that ART, in order to provide viral suppression, which is associated with extended survival rates. However, there are some limitations that come along with lifelong oral therapy. That includes pill burden, compliance concerns, cost, and adherence. Adherence is a key counseling point for patients because the key to successfully maintaining viral suppression is adherence to their prescribed regimen with continual access to care. Patients are considered adherent to their regimen if they are taking about 95% of their prescribed regimen, meaning that they can miss no more than 1 dose per month. Circling back to the HIV life cycle, the first stage of the life cycle is this entry. Surrounding the core of the HIV virus are the surface glycoproteins known as GP120, which I have circled on the slide here. The virus utilizes the GP120 on its surface to bind to the CD4 receptor on the human cell surface. However, this can only fuse into the cell with the co-receptors that complex the CD4 cell, as I have circled now. Maraviroc is an agent that's considered a binding inhibitor, and it prevents entry of the HIV into the target cells by binding to one of those co-receptors known as CCR5. However, there are multiple co-receptors on the CD4 cell surface. Therefore, Maraviroc will not work if that CCR5 co-receptor is either not present or if there is another co-receptor present. Therefore, we can actually test to see what co-receptor the patient has with a co-receptor assay test known as Trofile. Therefore, this viral tropism assay should be performed in all patients before initiation of Maravroc, the CCR5 antagonist. The other medication directed against the first stage in the HIV life cycle is fostemsavir, sold under the brand name Rukobia. This is a newer medication to the market, and it has its novel mechanism of a GP120 directed attachment inhibitor. And I will discuss this more in depth at the end of this presentation. Once that virus has bound with the CD4 cell, the HIV envelope and CD4 cell membrane will fuse together, allowing the virus to release its genetic material, or its RNA and enzymes, into the CD4 cell. The anti-retroviral, or ARV, against this stage is sold under the brand name Fusion. Fusion is not considered a first-line regimen for various reasons. For starters, it's available as a reconstitution powder that needs to be administered twice daily subcutaneously by the patients themselves. It's associated with an increased risk of some injection site reactions, and it has only been associated and studied in patients with virological failure. Once that virus has fused and releases its genetic material, an enzyme called reverse transcriptase is utilized to convert the HIV RNA into HIV DNA. Therefore, the ARVs here are reverse transcriptase inhibitors. We have nucleoside reverse transcriptase inhibitors, or NRTI, on the left-hand side of this table, and non-nucleoside reverse transcriptase inhibitors, or NNRTIs, on the right-hand side of this table. These reverse transcriptase inhibitors will inhibit that enzyme, thereby preventing the virus from replicating. And I would like to note that our NRTIs are big agents that are used especially in first-line therapy for treatment-naive patients. Now, once that virus RNA is converted to DNA, the viral DNA is then transported across the nucleus, where the HIV protein integrase will integrate the HIV DNA into the host DNA. So here our ARV regimens are considered integrase inhibitors. This medication class is a little easier to remember because all of the medications end with the same ending, which is Gravir, or GRAVIR. Now, once we have that immature virus, it'll move to the surface of the host CD4 cell. It releases protease, which is actually an HIV enzyme that's required to chop up these long protein chains of the immature HIV virus. Chopping up the protein chains will make functional units, making it mature and infectious. Here we have our protease inhibitors, atazanavir and darunavir, to be used in combination with either ritonavir or cobixistat. Can anyone tell me what the use of ritonavir and cobixistat are? So what is their place in therapy to be utilized with protease inhibitors? And if you want to unmute yourself and say it, or put your answers in the chat, that would be great. And if you don't know, that's okay. Yes, thank you, Steph. So they are used specifically as boosters or enhancers. So they are 3A4 inhibitors to boost the effect of the protease inhibitors by reducing the metabolism of atazanavir and darunavir. Now, taking all that information and applying it to the guideline recommendations. As I mentioned before, ART should be initiated as soon as possible after a positive HIV diagnosis. Generally, for treatment-naive patients, the guideline recommendations are having a 2 NRTI background. So we want a dual backbone therapy of nucleoside reverse transcriptase inhibitors in conjunction with our integrase inhibitors. So it's a 3-drug regimen. The one caveat to this recommendation, where it's recommended and allowed to have only 1 NRTI with an integrase inhibitor, is a specific medication sold under the brand name Dovato. Since Dovato only has 1 NRTI, it does not have that dual backbone therapy. There are specific implications, being that Dovato cannot be used in patients that have a high viral load, so a viral load greater than 500,000 copies per milliliter, or when results of resistance testing for reverse transcriptase are not available before initiation. In certain clinical situations, recommendations of initial regimens can include that dual backbone therapy plus either an NNRTI or a protease inhibitor with a booster. Thereafter, if we suspect or have a confirmed virological failure, a thorough assessment of whether one or more factors could have been the cause of failure is recommended, including if this failure is due to resistance, whether it be innate resistance of an ART regimen having a low barrier to resistance. At this point, with confirmed virological failure, a new therapy should include at least 2 and preferably 3 fully active agents. Now, a fully active agent is one that is expected to have an uncompromised activity after considering the patient's ART history, current and previous resistant test results, as well as if there is a new viral antiretroviral drug with a new mechanism of action available. Now I have an asterisk listed next to 2, and this is because these are actually updates to the 2021 guidelines developed by the Department of Health and Human Services. So before 2021, patients with virological failure were recommended to have 3 fully active agents. This has since been changed to only 2 fully active agents if we are utilizing a medication that is noted in the guidelines to have a high barrier to resistance. And a high barrier to resistance, some examples for you are second generation integrase inhibitors like dolutegravir and bictegravir. Thereafter, if patients are continuing to fail therapy, clinicians may consider enrolling these patients in clinical trials. And there is also that new medication, Rukobia, that I mentioned that I will discuss later in this presentation. The 2 surrogate markers that are used to monitor patients with HIV is their plasma HIV RNA, so their viral load, and their CD4 T lymphocyte cell count. The viral load is the most important indicator of treatment response to ART, and it should be measured in all patients with HIV. The viral load should be measured before initiation of ART and within 2 to 4 weeks after we start patients on regimens to confirm an adequate response. Repeat testing is recommended to be continued every 4 to 8 weeks. However, this monitoring requirement can be extended to once every 6 months if patients are adherent and they have a suppressed viral load for more than 2 years. The goal here is an undetectable load, generally defined as less than 200 copies per milliliter, because an undetectable load means untransmissible infection. And it also is associated with a reduced risk of progression to AIDS or death. However, I did want to note that the guidelines do note there are some patients that have an HIV RNA of less than 400 copies per milliliter, and it is not an indicator of treatment resistance or treatment failure. Thinking about the CD4 T helper cell count, this is required to be monitored because it's the strongest predictor of subsequent disease progression, survival, and assessing the immunological response to ART regimens. It is also a key factor in determining the need to initiate opportunistic infection prophylaxis and the urgency required to initiate ART. This also needs to be measured at the entry of care, so before we're starting these ART regimens, and then recommended every 3 to 6 months. However, this monitoring parameter can also be increased to once every year if patients are adherent to their regimens and have a virally suppressed load for 2 years, and if their CD4 cell count is greater than 500 cells per cubic millimeter. Next, I will give a brief medication overview. I will be utilizing these abbreviations on subsequent slides. So if you would like to take a moment and maybe take a picture of this to refer back to, that would be great. Okay. These regimens on this slide are recommended initial regimens for most people with HIV due to their durable virological efficacy, as well as having a favorable tolerability and toxicity profile. Drawing your attention to the top 3 medications on this slide, we have Biktarvy, Triumeq, and Dovato. These are all once daily regimens. It's 1 pill once daily, which may be enticing to some patients because of that decrease in the pill burden. As we discussed earlier, though, Dovato is only a 2-drug regimen, and it does not have that dual NRTI backbone therapy. Because of that, it can only be used in patients that do not have a high viral load. The other options at the bottom of the screen include Tivicay or Izentris, which are both integrase inhibitors, plus either Truvada or Descovy. And Truvada and Descovy have our dual NRTI backbone. They are both M-tricytidine and tenofovir. The difference between Truvada and Descovy actually lies in the salt component of the tenofovir. Truvada is tenofovir disoproxil fumarate, or TDF, and Descovy has tenofovir alafenamide, or TAF. TAF is a newer salt form that gets higher concentrations within the cell, thereby reducing the concentrations in the blood, thereby decreasing the side effects that we're concerned about with Truvada. And those side effects that we want to look out for with Truvada include renal and bone effects. So for example, then if you have a patient with a reduced creatinine clearance, or you have an elderly patient with osteoporosis, thinking about Descovy might be a better option than Truvada. One benefit with Truvada, though, is it has been noted to decrease lipid levels, so it may be a better option compared to Descovy in a patient that has uncontrolled hyperlipidemia. Counseling on those first-line medications that was on the previous slide. So as I mentioned, Biktarvy, Triumeq, and Dovato, they're all one tablet by mouth once daily. They can be taken with or without food. I did want to take a moment and point out specific dosing recommendations in terms of conjunction of these medications with polyvalent cations and antacids. There is this specific recommendation that patients will need to take their HIV regimen 2 hours before or 6 hours after taking an antacid or polyvalent cation. However, this separation requirement is not indicated if patients are taking their antiretroviral with food. So for example, if you have a patient who takes food and needs to take Tums with their food, and at the same time wants to take their HIV regimen, that is okay, and they would not need to separate their HIV regimen from the antacid. Focusing on Biktarvy, Biktarvy is well tolerated, and I wanted to note that it is active against hepatitis B because it has tenofovir and M-tricytidine in its backbone. Therefore, an important counseling point here would be any patient who has an active hepatitis B infection should not be suddenly discontinuing Biktarvy because it could exacerbate that hepatitis B, and it could also increase the risk of liver toxicity. Focusing on Triumeq, Triumeq has abacavir, which is an NRTI in its backbone. Abacavir has a specific risk of hypersensitivity reactions. And this risk of hypersensitivity reactions is significantly increased if patients have an allele called HLA-B5701. Therefore, the guidelines recommend testing all patients for HLA-B5701 before starting Triumeq, and it is not recommended to start Triumeq or any HIV regimen that has abacavir in it before these test results are either back or if a patient is positive. Dovato, like we mentioned before, is not implicated in patients with a high viral load, and its side effects are fairly well tolerated, most common being headache, diarrhea, nausea, insomnia, and fatigue. Counseling on our non-nucleoside reverse transcriptase inhibitors, focusing on rilpivirine and efavirenz. Rilpivirine is a drug component found in Julaca, Odefsey, and Complera, which you may have seen before. Rilpivirine needs to be taken with meals, and this is a requirement that I have seen in some orders already, noted in the notes for the nurses to administer rilpivirine with meals. And most common side effects we want to look out for are QTc prolongation and depression. There are specific drug interactions with rilpivirine as well. So rilpivirine is contraindicated with all proton pump inhibitors. However, if you have a patient that is having trouble with acid reflux, we can recommend the use of H2RAs and antacids as long as they are being separated with the requirements listed on this table. Now focusing on efavirenz, it's a drug component found in Atripla and Sustiva. Atripla used to be a first guideline recommended therapy for our treatment naive patients. However, it has since been removed, and that can be attributed to the adverse effects they were seeing. Those adverse effects being QTc prolongation and these weird abnormal dreams, depression, and increased risk of suicidal ideation. Efavirenz is also a major CYP3A4 inhibitor and inducer, so checking for drug interactions may be very important. Now transitioning to talk about our protease inhibitors. So our protease inhibitor-based regimens include atazanavir or darunavir, plus either ritonavir or cobixistat. Major side effects with protease inhibitors are cardiac effects. So atazanavir and ritonavir have been noted to have PR or QTc prolongation. And protease inhibitors are major CYP3A4 inhibitors. So anytime we're seeing protease inhibitors in a patient's HIV regimen, it may be influential to look for some drug interactions. Boiling that down into specific considerations, I know patients are typically on various regimens and not the ones that I discussed earlier. So these might be some key considerations to look out for when verifying HIV medications. Patients with a creatinine clearance less than 50 milliliters per minute, it's recommended to avoid TDF, so that tenofovir disoproxil fumarate that's found in Truvada. Patients with a creatinine clearance less than 30 mils per minute, it's recommended to avoid TAF, which is found in Descovy, Triumeq, Biktarvy, and Dovato. However, if patients have this reduced creatinine clearance and they are on hemodialysis, TAF and Biktarvy may be utilized. For patients with a co-infection of HIV and hepatitis B, it's recommended to pick a regimen that has emtricitabine, lamivudine, and tenofovir because they are active against hepatitis B. Patients with osteoporosis, it's recommended to avoid TDF. Patients with psychiatric illnesses, it's recommended to consider avoiding efavirenz and rilpivirine-based regimens because they can exacerbate psychiatric symptoms and may be associated with an increased risk of suicidal ideation. Integrase inhibitor-based regimens are also recommended to consider avoiding because they have been associated with adverse neuropsychiatric effects in some retrospective cohort studies, as well as some case studies. Patients with an opioid use disorder who are being treated on methadone, avoid efavirenz components because efavirenz will actually decrease the methadone concentration, thereby increasing the risk of opioid withdrawal. Cardiac and QTc effects, consider avoiding, of course, our protease inhibitors, efavirenz, as well as rilpivirine. And then hyperlipidemia, the following medications have all been associated with dyslipidemia. So our protease inhibitors either boosted with ritonavir or cobixistat, efavirenz, or elvitegravir boosted with cobixistat. And then just as a reminder, TDF can actually lower lipids. And then again, abacavir, making sure we have that HLA-B5701 allele testing available, and it should not be indicated in patients who have a positive HLA or if it's unknown. So my first presentation question is, you have a patient who presents with symptoms consistent with GERD. Upon medication review, you notice the patient is taking Complera, which components are emtricitabine, rilpivirine, and tenofovir. What is an appropriate recommendation for the team to control this patient's GERD symptoms? Keeping in mind that rilpivirine is that NNRTI that I talked about earlier with those specific drug interactions. Correct. So the answer here is C, Tums. And the key point here is that rilpivirine requires an acidic gut for absorption, and it should be avoided with all proton pump inhibitors. We can recommend the use of H2RAs and antacids as long as it is adequately separated. Now, the next question is, a patient's HIV regimen includes Evotaz, which is atazanavir, and cobixistat, our protease inhibitor that's boosted. Which of the following medications interact with Evotaz? Okay, so I see the answer is A, and that is correct. However, the answer here is E, all of the above. Now, if we remember from before, protease inhibitors are strong 3A4 inhibitors. So we want to make sure we're checking for drug interactions, especially when these regimens are being used. I specifically picked medications that are all listed as category X in Lexicomp, but checking for the 3A4 inhibitors is going to be really important. Now thinking about HIV and pregnancy, All pregnant women with HIV should initiate ART as early in their pregnancy as possible, regardless of their HIV RNA levels or their CD4 count, to maximize their health and prevent perinatal HIV transmission. This is because earlier viral suppression has been associated with lower risks of transmission. If there are patients, however, that are already on a fully suppressive regimen when pregnancy occurs, it is recommended in most cases to continue the regimens that they're already on to maintain an HIV viral load that is below the limit of detection. There are specific medications, though, that are listed in the guidelines to not be recommended. One of these being bictegravir, which is found in Biktarvy, due to limited data on the use in pregnancy and lack of safety data. Darunavir, atazanavir, and elvitegravir, all boosted with cobixistat, are not recommended, as they have all been found to have an increased risk of urological failure in pregnancy due to pharmacokinetic changes in pregnancy that pose a risk for lowered drug levels and viral rebound in the second and third trimesters. Cobixistat in general should be avoided in pregnancy because its levels are lower during the second and third trimester. Now, what if we have a pregnant woman presenting who does not have viral suppression? So her RNA load is greater than 1,000 copies per milliliter, or her status of her RNA levels is unknown, and we have some assumptions that she is non-adherent to her regimen. Guidelines recommend to schedule a C-section, and there is actually an intrapartum intravenous medication that we can recommend for this specific population. Does anyone know what that medication is? Correct. It is IV zidovudine. So zidovudine is specifically recommended in these pregnant women who have an RNA of greater than 1,000 copies per milliliter or unknown near the time of delivery. It's recommended to be started at least 3 hours prior to the scheduled C-section or when they present in labor. The dose is a 2 milligram per kilogram load followed by a 1 milligram per kilogram per hour continuous infusion to be continued for a minimum of 3 hours or until clamping of the umbilical cord. Therefore, IV zidovudine would not be recommended in patients that meet all of these following criteria. So if you have a pregnant patient who has HIV, but they are receiving ART, they are adherent, and they have an RNA of less than 50 copies per milliliter, IV zidovudine would not be recommended. Now let's compare those HIV regimens to regimens that are utilized in pre-exposure prophylaxis and post-exposure prophylaxis. Pre-exposure prophylaxis is a medication that's indicated to be taken before high-risk activity, to be taken consistently once daily. There are currently 2 FDA-approved medications specifically for the use in PrEP. Does anyone know what those 2 regimens are? And they are regimens that we talked about earlier in the presentation. Exactly. So Truvada and Descovy are the 2 PrEP medications that are currently FDA approved. Now, before we begin patients on PrEP, there are specific monitorings that need to be completed. So we always need to have HIV testing, hepatitis B serology, and hepatitis C testing, as well as STIs. The question that I now have for everyone on this chat is, let's say we have a situation where a patient reports being interested in starting PrEP. However, they endorsed that about 2 weeks ago, they had a risky behavior. How long would we have to wait to ensure that the HIV testing result we're getting is definitively either positive or negative for HIV? Is it a few weeks? Is it a few months? Or could it take up to a year maybe? Yes, so a few months is correct. It's specifically listed in the guidelines to wait 3 months if there is an exposure before starting PrEP. And that's because there is a lag time in antibody production, and testing sooner than 3 months could result in a false negative. So if we tie that back to the regimens that are approved for PrEP, Truvada or Descovy, Truvada and Descovy are only a 2-drug regimen, so it does have that dual NRTI backbone therapy. However, first-line guideline recommended medications for positive HIV patients includes a 3-drug regimen. Therefore, if we start PrEP before getting an adequate negative result, we could potentially not be treating their positive HIV infection and risk not being able to suppress their viral load. How long does a patient need to take PrEP before it's highly effective? So there's actually not a scientific consensus on what the exact days to effect are. However, there is data from exploratory PK studies that were conducted in patients who were HIV uninfected that provided preliminary data on the lead time required to achieve steady state levels of tenofovir in the blood, rectal, and vaginal tissues. These studies suggested that for patients whose at-risk behavior is receptive anal sexual intercourse, it takes about 7 days to reach high effectiveness. For patients whose at-risk behavior is receptive vaginal sexual intercourse or injection drug use, it takes about 21 days. And unfortunately, there is no data for patients whose at-risk behavior is insertive sexual intercourse. Comparing that regimen to post-exposure prophylaxis, PrEP is indicated for patients after an HIV exposure, whether it be a non-occupational exposure or an occupational exposure. So for instance, a healthcare worker who accidentally gets a needle stick. The regimens indicated for PEP are Truvada plus Tivicay or Izentress. Thinking about this again, we now have a 3-drug regimen with 2 NRTIs and an integrase inhibitor to actively treat against a potential for a positive HIV infection. It needs to be taken once daily for a full regimen of 28 days. My question now is, after an HIV exposure, when is it recommended to start PEP? How many hours should PEP be started within? Exactly. So the recommendation here is 72 hours. However, PEP ideally should be started within 2 hours, and we should not be delaying therapy while waiting for HIV status like we do in PrEP, because time here is of the essence to prevent that virus from replicating. This brings me into my next case question. There is a 32-year-old male who reports with an HIV negative result from an over-the-counter or a quick testing kit. He endorses taking the test 2 weeks after risky behavior, and he now reports interest in starting PrEP, so that pre-exposure prophylaxis. The team gets negative hepatitis and STI testings, and now the team is ordering Truvada, which is an adequate regimen for PrEP. However, do you agree with this negative result? Yes or no? Great. So the answer here is no. And the answer is no for a few reasons. So the first reason is this patient endorsed taking the test 2 weeks after risky behavior. If we remember, there is about that 3-month lag effect. So we could therefore be starting a PrEP regimen without a positive HIV negative result. The other recommendation here that makes this choice no is because the OraQuick over-the-counter testing kits is just a swab of the upper or lower gum. So it's just a test of their saliva that has to be sent into a lab. It is recommended for any positive or negative OraQuick testing. It needs to be confirmed in a laboratory with a blood sample. Looking now into treatment failure and resistance. The guidelines developed by the Department of Health and Human Services define virological failure as a confirmed viral load greater than 200 copies per milliliter. There are various reasons why someone could develop resistance to an ART therapy. For starters, patients can develop resistance when on a particular ART medication. The virus can mutate the specific medication, resulting in therapies becoming ineffective. Also, patients who miss their doses frequently are at greater risk of developing resistance. However, even if a patient is taking a medication exactly as prescribed, if we're having problems with absorption, the body will not successfully prevent HIV from replicating, leading to resistance. Additionally, resistance can actually be transmitted from person to person as well, and there is cross resistance as well as cross tolerance between the HIV classes. So if you have a patient that has resistance and we're unable to suppress their viral load, their CD4 count is going to fall, and that's a decrease in their immune function. As you can see on this graph on the right-hand side of the slide, as the CD4 cell count is falling, there's a gradual increase in the amount of opportunistic infections. And opportunistic infections typically need to be treated inpatient. I included this table with opportunistic infections with the initial preferred regimens for your reference. Now transitioning into discussing new antiretroviral therapy options. In January of 2021, the FDA approved a new long-acting monthly injectable sold under the brand name Cabenuva. Generic is cabotegravir and rilpivirine. This medication is really groundbreaking as it now reduces patients' treatment dosing days from 365 days a year to 12 days a year. That is less time that they need to worry about remembering to take their medications and potentially be reminded of the stigma surrounding HIV. Cabenuva is available in 2 formulations as a co-packaged monthly injectable, as you can see on the picture on the right-hand side, and as well as an oral tablet as separate components. The dosing for Cabenuva is an intramuscular injection that needs to be administered by a healthcare professional in a healthcare professional's office. There is this higher loading dose followed by monthly continuation doses that are slightly lower. The efficacy of Cabenuva was evaluated in 2 phase 3 randomized parallel arm non-inferiority trials that were active controlled, the FLAIR and ATLAS trials. The FLAIR trial specifically looked at patients with a positive HIV infection that had not had previous ART history. They were included if they did not have virological failure and did not have NNRTI resistance. The primary endpoint of the FLAIR trial was the percentage of participants with a plasma HIV RNA level of 50 copies per milliliter or higher after 48 weeks. Participants all started on the same regimen, dolutegravir, abacavir, and lamivudine, and if we remember, that is sold under the brand name Triumeq. After 16 weeks of this regimen, if they had an HIV RNA level of less than 50 copies per milliliter, they were then randomized in a 1-to-1 ratio to either continue receiving that oral comparator of Triumeq or transitioned into long-acting therapy injections with Cabenuva. As you can see, however, these patients for the first month were required to start on the oral cabotegravir and rilpivirine. The reason for this was to assess safety and tolerability before transitioning into those long-acting monthly injections. At week 48, the HIV RNA levels of 50 copies per milliliter or higher were found in 6 participants receiving the long-acting therapy and 7 in those receiving oral therapy, which accounted for an adjusted difference of 0.4 percentage points that did meet the criteria for non-inferiority. The ATLAS trial varied from the FLAIR trial because they looked at patients that had already been receiving ART for 6 months. The primary endpoint was the same for the ATLAS as it was for the FLAIR trial. They randomized these patients to either continue their ART regimens that they had been previously on or to receive the long-acting injections. And again, they started off these patients on the oral cabotegravir and rilpivirine to assess safety and tolerability and then transition them into the monthly injections. The ATLAS trial found that at week 48, the RNA levels of 50 copies per milliliter or higher were found in 5 participants receiving the long-acting therapy and 3 receiving oral therapy. This accounted for an adjustance difference of 0.6 percentage points, which also met the criteria for non-inferiority. The ATLAS trial also did a good job at explaining adverse events. So as you can see on the top hand of this table, the reported adverse effects were higher in the long-acting therapy group than in the oral therapy group. 95% of patients who received that long-acting Cabenuva injection reported adverse effects, whereas 71% of patients reported adverse effects with the oral therapy. The differences in these adverse effects can be largely attributed to injection site reactions. So of those 95% of patients that reported those side effects, 81% of those were attributed to injection site reactions. However, only 99 or 99% of those injection site reactions were mild or moderate, 0 were life-threatening or fatal, and only 1% of participants actually discontinued treatment due to the injection site reactions. The injection site reactions did typically resolve within 1 week. And it's interesting because the majority of these reactions were reported after the first initial dose with that higher dose of cabotegravir and rilpivirine. As you can see, 69% of patients reported that injection site reaction post initial dose, and that decreased to 11% with those subsequent monthly doses. Also, the type of injection site reaction that was noted, 75% was attributed to localized pain and localized discomfort. The ATLAS trial also evaluated patient-reported outcomes. They looked at patient satisfaction with this HIV treatment satisfaction questionnaire, or HIV TSQ. After 44 weeks, participants in the long-acting therapy group with Cabenuva reported substantially greater improvement from baseline in their treatment satisfaction. The adjusted mean increase in score from baseline was 5.68 times higher in that long-acting group than in the oral therapy group. And when asked, about 86% of participants selected the injectable regimen over their daily oral therapy as their preferred HIV treatment. In conclusion, together, the FLAIR and ATLAS trial show that the long-acting injection of Cabenuva effectively can maintain HIV suppression. Its place in therapy, therefore, will be for patients who have sustained viral suppression for 3 to 6 months on ART with no resistance to rilpivirine or cabotegravir, and this is reflected in the updates to the guidelines in 2021. Thinking about the storage and handling, so it is available as this co-packaged injection, as you can see on the right side. It's available as a separate cabotegravir and rilpivirine vial. So it's going to be 2 injections that are intramuscular, intragluteal at a healthcare professional's office. It needs to be stored in the refrigerator. And once it's removed from the refrigerator, these vials must either be used or discarded. The dosing schedule with Cabenuva is as follows. All patients will need that oral lead-in phase that we saw in the FLAIR and ATLAS trial. So it'll be 1 tablet of cabotegravir and 1 of the rilpivirine, again, to assess tolerability and safety. If that can be confirmed, then patients can transition into that long-acting injection, again, with the one-time higher doses for the first month, and then followed by those lower doses with the continuation injections. It's recommended that Cabenuva is administered at the same time every month. So these patients will have a treatment target date. As you can see on this calendar, that number 10 in orange is exampled as someone's treatment target date. As we know, much like for us, it's not always feasible to get an injection at the same time every single month. Because of that, there is flexible dosing that allows for continuation injections to either be given 7 days before their target date or 7 days after. However, if this is not enough with that 7-day window and patients are planning to miss their injections, they can be transitioned by their healthcare providers to the oral tablets. So they would be taking 2 tablets once a day monthly, and that can replace up to 2 consecutive monthly injection visits. After those 2 months, or even if it's just 1 month, these patients can immediately be transitioned right back to the long-acting injectable therapy. Monitoring for Cabenuva includes QTc prolongation, and hepatotoxicity has been reported in patients with Cabenuva. And then behavioral health is always an important counseling point and monitoring point for patients living with HIV. Now transitioning into a new medication, Fostemsavir, sold under the brand name Rukobia. It was approved in July of 2020. And as I mentioned before, it's a GP120 attachment inhibitor. It's its first and only in class with this mechanism of action to prevent viral entry by binding to that GP120 envelope on the surface of the HIV virus. Its dosing is a tablet form, 600 milligrams twice daily. Most common adverse effects with Rukobia are nausea, followed by diarrhea, headache, and sleep disturbances. Sleep disturbances reported as abnormal dreams as well as insomnia. Serious adverse effects are transaminase elevations. However, in the clinical trial that got Rukobia approved, the BRIGHT trial, this was only found in patients that had co-infections with hepatitis B and C. Therefore, monitoring of liver chemistries is only recommended in patients that have that hepatitis co-infection. Rukobia is also a QTc prolonger, so checking for drug interactions that also prolong the QTc. And then there is a specific drug interaction with ethinyl estradiol, so it can actually increase the effects of the ethinyl estradiol, thereby increasing the risk of thromboembolic events. Its contraindication is co-administration with strong CYP3A4 inducers, so checking for drug interactions with Rukobia will also be a good point. Its place in therapy is specifically for heavily treatment experienced patients with multiple or extensive drug resistance with few treatment options. The goal for these patients as a last line therapy is resuppression if possible, otherwise keeping that viral load as low as possible and CD4 count as high as possible. Now, I wanted to end today's presentation discussing some HIV global statistics and the United Nations 90/90 treatment for all goal. At the end of 2020, an estimated 81% of patients living with HIV who were HIV positive actually knew their status. Only 67% of those patients were achieving the care that they needed. And only 59% of those patients receiving ART had a suppressed viral load. The 90/90 treatment for all's goal is that 90% of patients living with HIV will know their status. 90% of those patients who know their positive status will have access to care, and 90% of those patients on ART will be virologically suppressed. Getting patients more access to care and encouraging adherence to their prescribed ART regimens is crucial to help make strides in decreasing the stigma surrounding HIV and reduce potential future healthcare costs and mortality rates resulting from progressions of HIV infections if it's not properly treated. I included this, these are the medications that I talked about today that are available on our formulary. This is not an extensive list, and I do want to note that since Stony Brook is a designated HIV treatment facility, we can always order any medications that are non-formulary for these patients. Here are some references for pictures that I did not include on the slides. And that concludes my presentation. Thank you everyone for attending. I hope this was informative, and now I will open it up for any questions that you guys may have. Thank you. Okay, so seeing no questions, I will log out. If you weren't here in the beginning of the presentation, if you could please type your full name in the chat so I can write your name down for CE credit, that would be awesome. And then I will send everyone post-assessment questions as well as with a CE code for credit. Thank you all again for taking the time to join today, and have a good evening.